Dr. Ali, can I ask about Mrs. Layla, who's with me next door, please?
Yes, sure.
Sure. I've got the notes here just to read from it. And
Go ahead.
so basically, she is a 50-year-old lady with gastric adenocarcinoma with liver metastases. She was diagnosed about 2 years ago. And because she had HER2-negative disease, she received Folfox for nearly 6 months, progressed, and then she had Paclitaxel, Ramucirumab. She stayed on that for about a year, but unfortunately, recent CT scan showed disease progression. She remains in an excellent performance status, ECOG1, and she's highly interested in therapy, but she's not interested in clinical trials though. So I'm not sure what else could we offer her.
This is a very good course, actually.
Yeah.
Do we have the PD-L1 and MMR?
Yes, of course, yes. She is proficient mismatch repair. Her PD-L1 is 0% expression. According to the NCCN guidelines, for second-line or subsequent therapy for unresectable locally advanced, recurrent or metastatic gastric or gastroesophageal junction adenocarcinoma, the options include Ramucirumab and Paclitaxel, Ramucirumab single agent, Docetaxel, Paclitaxel, Irinotecan, and finally Trifluridine Tipiracil. Pembrolizumab would also be an attractive option as second-line or subsequent therapy if the patient has deficient mismatch repair gastric cancer. Additionally, it is also approved for third-line or subsequent therapy for gastric adenocarcinoma with PD-L1 expression levels by CPS of 1 or more, or high tumor mutation burden, more than 10 mutations per megabase. Trastuzumab deruxtecan has also been FDA approved for adult patients with locally advanced or metastatic HER2-positive gastric or gastroesophageal junction adenocarcinoma who have received prior trastuzumab-based treatment.
We have with us Mr. Kerry. He's a 64-year-old with a significant smoking history, and he presented with 6-month history of dysphagia. EGD showed a large esophageal mass above the carina, and the biopsy confirmed squamous cell carcinoma. She had a PET CT, and we're here to review it today.
Sure, Dr. Ahmed. Actually, the PET scan showed a large 5 centimeter FDG avid lesion localized in the cervical esophagus, consistent with a primary cancer. No FDG avid lesions anywhere else. So the overall stage is T3 N0 and M0.
Okay. Do we have any recommendations from oncology?
For tumors at or above the carina, a bronchoscopy is needed to rule out a fistula. Cervical esophageal cancers that are located less than 5 centimeters from the cricopharyngeal muscle should receive definitive chemo-radiotherapy. Either concurrent therapy with cisplatin 5-FU or carboplatin Taxol would be reasonable options. As per the NCCN guidelines, esophagectomy should be considered for all medically fit patients with localized resectable esophageal cancer more than 5 centimeters from cricopharyngeal muscles, particularly if the patient has a T1b, T2, N0 low-risk lesion, i.e. less than 2 centimeters in size, and well-differentiated cancer.
So our next MDT patient is Mr. Nadi. He's a 49-year-old, and he was diagnosed with gastric cancer, adenocarcinoma, 2 weeks ago. And preoperative staging was a T1, N0, M0, and now he had a partial gastrectomy, and we are here to discuss the pathology.
Right. The surgical specimen contained a large adenocarcinoma that penetrated the subserosal connective tissues but does not reach the serosal surface. 16 lymph nodes were resected, 2 had cancers. The margins were clear. The final staging is PT3 in one are not. And this was a D1 surgery.
We were not expecting that. So, what should we do?
Our colleagues, oncology. Patients with gastric cancer who have undergone surgery but did not receive preoperative chemotherapy or chemo-radiotherapy and then found to have either T3, T4, any N or any T with positive node should receive adjuvant therapy. The two adjuvant options as per the NCCN guidelines include either fluoropyrimidine, 5-FU or capecitabine, then 5-FU based chemo-radiotherapy, then fluoropyrimidine if the patient has undergone less than a D2 dissection, or chemotherapy for patients who have undergone a primary D2 lymph node dissection.
Dr. Ala, I have with me Mrs. Suad, admitted to our ward 2 days back, and she was admitted with symptoms of dysphagia with no other symptoms. And we did for her an OGD which showed a mass in the upper third of the esophagus above the carina, and it was shown to be squamous cell carcinoma.
Right, okay, so has she had the CT scan done?
Well, we have done it, but we don't have the result yet. I will chase it today.
Good, perfect. So what else are we going to do for her? PET CT scan is particularly helpful to identify undetected distant metastases that could have been missed by CT scan. PET scan should therefore be carried out in patients who are candidates for esophagectomy, as the findings of otherwise unknown distant metastases may prevent patients from futile surgery. Bronchoscopy for tumors that are at or above the carina is also indicated to rule out invasion into the upper airway system. Esophageal cancers rarely metastasize to the brain, so without concerning CNS symptoms such as headaches or visual disturbances, MRI or CT head is not indicated. Laparoscopy can be considered for tumors near the GOJ junction, as these tumors do have a high tendency of occult peritoneal metastases.
We hope you liked our video. This is acting for clinical education.
And don't forget to check the reference down below.
Please like, share and subscribe, and don't forget to join us every Thursday 5 p.m. Greenwich time.